You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 28, 2023. Our topic today, oral challenges to foods. Our presenter is Dr. Justin Greiwe. He's a clinical assistant professor of medicine in the Division of Immunology and Allergy at the University of Cincinnati in Cincinnati, Ohio.
Welcome everybody to our second Conferences Online in Allergy today. Second presentation. This is August 28th at 11 a.m. We're fortunate to have Dr. Justin Greiwe on today. He's going to talk about oral challenges to foods. As many training programs, it seems to be a big part of our time now is doing lots of food challenges, so this will be very informative. Dr. Greiwe is with the Bernstein Allergy Group in Cincinnati. He's been there since 2014. Prior to joining the practice, he received his medical degree from the University of Toledo College, followed by pediatric residency at Rainbow Babies and Children's Hospital in Cleveland, and he went on to do his A&I fellowship at Cleveland Clinic also. Dr. Greiwe also serves as principal investigator at the Bernstein Clinical Research Center and is clinical assistant professor of medicine at the University of Cincinnati. So, Justin, thanks for being here today.
You got it, guys. This is a talk I've given in the past multiple times, but I think, we can always gain knowledge from real world experiences. So I definitely included some of those in this talk. I thought it'd be more interesting just to kind of give you some examples of what I saw last week as kind of like a day-to-day allergist practicing out in the real world. So we'll go over some referrals I've gotten in this space and maybe kind of get your feedback on what you might consider doing once you see the clinical case. So definitely interactive. Feel free to interrupt me at any point in time, but let's get into the nitty-gritty details. We're going to dive into oral challenges today, kind of really understand why they're so important for our patients, determining which patients are actually candidates for this, and how to perform these challenges safely and with confidence in your office. So, of course, it's no surprise that food allergy diagnosis affects quality of life. There's a lot of social and psychological consequences because of this diagnosis, and really patients can be very isolated, have a lot of anxiety and fear, and patients and parents both, of course, are very anxious in general. There's different kind of cohorts of patients and parents and how they respond to this diagnosis. There's some that kind of really go, one side of the pendulum and are very strict and, limit their kids' access to any and all foods that might be cross-contaminated. They don't go over to sleepovers or birthday parties. They go to baseball games. And so they're really, and some even don't fly. So that there's this pendulum that swings one way. There's another pendulum where parents and kids are kind of laissez-faire about the whole situation, might have a few accidental exposures here and there, but don't think it's that big of a deal. And then, of course, there's everyone in between. But I think really the ones that are really affected are those patients on that pendulum of isolation, and that can really affect people long term. We've had some really good quality of life surveys done before and after oral food challenges that showed significant improvement, really irrespective of the outcome, whether there was a failure or a pass. Parents and children tend to view the experience positively. So, I think a lot of people shy away from these because they're nervous and concerned that, they might lose trust from the kids or the parents that they're treating with food allergies. And how could you expose my kid to this awful reaction? But in reality, as long as you're having the conversations with parents beforehand and really kind of going over the process and there's no surprises, I've never had anyone that has been upset with me due to a failed challenge. So it really is, taking things into context and really making sure that you're explaining things in detail. So, of course, oral food challenges are the gold standard for diagnosing a food allergy. And as we can see in this presentation and what we'll see in some of the surveys we've done, it's definitely underutilized. There's different reasons for that. Very little of it has to do with experience. A lot of it has to do with time and kind of a busy clinical practice. These challenges take up a lot of time and effort, and they're not really reimbursed very well. So some physicians don't feel that they're worthwhile. But it's important to have an idea of where these might fit in your clinical practice once you go out into the real world, and how you're going to interpret the tests that you're going to get, whether that's skin testing, blood testing, or both. So, there's lots of reasons to perform challenges And, of course, the most common would be, ruling in or ruling out a food allergy. There's, other reasons to consider challenging. We talked about parental and patient anxiety before, and definitely having a really anxious kid that you're pretty confident does not have an allergy. Even though you might have all negative tests and the clinical history isn't consistent, sometimes bringing them back for a challenge, even though the risk of them doing that at home is very low, gives parents and patients the confidence to introduce some of these foods. I can't tell you how many times I've kind of brushed over, a pine nut allergy or a macadamia nut allergy or something where, like, go ahead and introduce it at home, no big deal. And, a year or two later, they'll come back and they're still avoiding that food because they were too nervous to do it. So be honest with your parents and patients, and really kind of determine whether or not they feel confident doing this at home, because that definitely is a big issue in my practice. Of course, using challenges to kind of screen people for OIT is important. We do a lot of OIT in our practice. We've been doing that since 2014 when I first got out of the fellowship, and that's an important tool we have to kind of get people into OIT. We don't do it for every single OIT patient, but for a lot of them, we want to confirm or deny this as an allergy before we move on to a very kind of long and drawn out process that is OIT. Other scenarios, when you're looking at mollusks in a crustacean shellfish allergy patient, tree nuts in a peanut allergy patient, sometimes these things come up. Monitoring for resolution. You had a patient with really high egg or milk allergies, and those levels have come down over time, and you're ready to kind of see if that has resolved. So again, lots of reasons to perform challenges. And the nice thing about a challenge is it can really be concrete and give patients confidence and parents confidence that, either they have or do not have an allergy, and that gives them back some power, which is helpful. So, testing methods are things that you guys are learning about now in fellowship. Of course, skin prick testing and serum-specific IgE testing are the gold standard for now. There's definitely a lot of movement in this space. We've seen more and more opportunities to look at component testing, but also bead-based epitope assays, basophil activation tests, etc. So we're trying. We've realized the inadequacy of our current modalities. The positive and negative, the positive predictive value of these tests aren't great, and especially when you're trying to kind of analyze someone to say whether or not they might be a good candidate for a challenge. It would be great if we had a really good sensitive test to give ourselves and the parents confidence, like, man, if we do this challenge, your kid has a really good chance of passing. And we've used skin and blood testing for that to date, but as anyone who's practiced for a while knows, those tests are kind of very poor in assessing who's going to pass the challenge and who's going to not. Again, in a scenario where you don't have all negative tests and things like that, it's these gray zones that really make decisions difficult. In order to kind of tease out the gray zone area, again, bead-based epitope assays are becoming more popular. Verimap, Peanut Diagnostics is one of them. High negative and positive predictive values, if you look at it compared to previous tests we've had available, and really have a good concordance with a food challenge. So, in theory, this is eliminating, the art of medicine and making it more scientific in the food allergy space. These tests aren't, universally available. They can be expensive, but at least it's a movement in the right direction, giving us more data and more confidence when we're providing these challenges in the office. So definitely something to keep an eye on and potentially use when you go out into the real world. Basophil activation testing is also something that we've used occasionally in the past. Similar to the previous example, it's definitely helpful for those patients that have never eaten foods before, but they have really high levels of IgE or skin prick testing. We've definitely kind of potentially use this in situations where we're questioning whether or not this patient might pass. So, they're hard to get and sometimes hard to order, but in really nervous patients and parents, sometimes this can be helpful. And hopefully, as it comes out of academia and into the real world, costs will come down and it'll be easier to order. Of course, component testing has been out for a while, and as you'll see when you study for the boards and everything else, you're going to find, okay, what are the components that I'm most worried about? I listed a few here for peanuts, tree nuts, milk and egg, but I definitely use component testing as an initial diagnostic, but also in monitoring my patients on OIT over time. And oftentimes you'll see significant drops in, RH2, for example, with peanut in a patient that's been placed on OIT. So it's a nice level to get, and also can be helpful, especially when you're determining whether or not patients might be good candidates for baked egg or milk challenges. So I'm definitely a proponent of these until, again, further, more accurate tests become available. Now, there's lots of factors that can modulate the interpretation of allergy results, and as you go out into the real world and start experiencing these types of scenarios yourself, you'll start to get the hang of some of these things. Atopic dermatitis can definitely cause issues with regards to interpretation. Can't tell you how many times I get an infant or a toddler who comes in who's had previous broad panel allergy tests as an infant with really severe eczema. And you'll see lots of false positives in a lot of those patients. So that can be a mess that you really have to kind of wade through in order to kind of figure out if the patient's truly allergic or not. So all these things can contribute to the age of the patient, the ethnicity. So take these into consideration when you're getting these blood or serum or skin tests, and make sure you're not getting some sort of outlier that might be kind of falsely leading you down the wrong path. So keep these in mind for sure. And then, of course, other factors influencing your decision to perform an oral food challenge as well. Some patients and parents are very, adamant, like, this food is very important to us, whether it's culturally or this is a food that he or she's constantly exposed to, and we just really need to answer. And it's a really important food for us, so we want to challenge. And so sometimes we'll use that as a reason to move forward with the challenge, even maybe if the chances of them passing aren't as high as we'd like. That can at least give patients and parents the final decision on, yes, this patient is truly allergic, especially if they've never eaten it before and have never had a reaction. So those might be scenarios where you challenge. Of course, we're thinking about history, the clinical history, and that's really outside of blood and skin testing. Like, there's all those pale in comparison to a quality clinical history. So that's by far and away the first thing you need to do, is really dive into the details, because oftentimes you've got your answer usually hiding in plain sight with a good clinical history. So never forget that. Don't rely on your blood and skin testing. Rely on your clinical history as the main thing driving your decision making when you're seeing food allergic patients. So these are all good things to think about when discussing food challenges with your patients. So there's so many pitfalls, as we mentioned, with these evaluations, and broad panel food testing is the bane of my existence. I tried to get a quality improvement project with Cincinnati Children's going, where we really kind of teased out how much wasteful spending was being put into these tests, as well as we were going to do this joint project, and it never got off the ground. But I'm pretty confident that there is a lot of wasted effort and money going into these broad panel food tests that are typically ordered by pediatricians, primary care doctors, sometimes other specialists like dermatologists. So this is kind of an example of a panel I got from a patient who came in to see me. I think this was maybe a year or two after they got this blood work drawn, and as you can see, just a really high total IgE, which I always get anytime I draw blood work for foods, just to kind of give me a baseline of where the IgE is sitting, so it helps with interpretation. But as you can see here, if you just showed me this result and took out the IgE and didn't give me any clinical history, I'd be like, oh man, this kid's allergic to a lot of different things. That stinks. This guy needs to avoid a lot of foods. But after a clinical history of basically never ingesting any of these things, this was all based off broad panel food testing as an infant, really bad eczema. Since it has improved, we actually challenged him to all these foods, and he passed every single one of them. So he was not allergic and continues to eat those today. But again, at face value, there'd be no way that you would consider challenging a kid with I think his sesame level 2, I listed on here. His sesame level was like 72, and he passed that as well. So, your book would say never challenge that kid, but again, this is real life. So you have to take everything into consideration when you're talking about these patients. So there's lots of factors that can affect the accuracy of the testing, as we've mentioned. We talked about clinical history. So a clear history of a previous reaction is very accurate, and really, especially when you're getting to higher levels on IgE, really confirmatory that this is a kid that's got an allergy. So, you know, in a kid with a sesame level of 72, I'm not challenging that kid if he, you know, 3 weeks ago just had an immediate reaction with hives, swelling, and shortness of breath. That's irresponsible. Now, an unclear history with a positive test is a different story. And as you can see here, even with peanut levels over 5, you know, 77% of those patients passed challenges. So again, don't take the blood work and the skin testing at face value, and these are really good indications of why. So before I get into the cases, any questions from the group to date? I know I'm going through this fairly quickly, but I wanted to make sure to get through a lot. Good? Okay. So if you can interact, and hopefully you can, maybe I'm just talking and you guys can't respond to me during this. So this first case is literally from last week. 8-year-old male with a history of allergies, OAS symptoms, and food allergies. He's presenting to me for a third opinion. He had a history of a reaction to an imitation crab at 3 years of age, some small redness around the lips, avoided the imitation crab, but continued to eat any other fish, shellfish on a regular basis. He was a big lover of shellfish and fish, and so he was eating them multiple times a week. Was seen by an allergist a year ago, secondary to seasonal allergies. And upon hearing this kind of remote history of maybe some hives around the lip as a younger kid, drew testing for fish and shellfish. And as you can see here, the blood work is shown and the skin testing shown. You know, we had multiple positives on both skin and blood testing based off of this history. So if you can answer me, what would be your recommendation to this patient after hearing about this remote history, but then seeing pretty significant levels on blood and skin testing for certain fish and shrimp? And maybe you guys can't respond.
No,
Oh.
I was going to try to give this a shot.
Okay.
But I guess based off of like the initial clinical history, it sounds like they had maybe just some contact irritation, potentially nothing diffuse. And it's hard to know, like, did they really have hives at the time? I guess when I've been in this situation in the past, when I go through the results and talk to the family, it's at that point kind of establishing like comfortability with the family and really assessing their education of, you know, the patient's been eating fish and shellfish this whole time. Like, are we really going to focus on this testing, or do we kind of initiate and kind of see, like, are they just not going to do it unless we do a challenge with them in clinic? I guess that would be kind of my recommendation, is pretty much more shared decision making. But maybe that's a little bit more cavalier.
Oh, okay. Any dissenting opinions or any other suggestions?
Yeah, I mean, I feel like if he's been tolerating the foods, I mean, I don't think there's any reason like this to go and challenge the kid. I mean, if he's been eating it like at home, I mean, just because of a positive test. Again, if he's been eating it, yeah, then there's no reason to kind of stop eating.
So just say ignore the test and just continue to eat the foods?
If he's been eating it, yeah.
Okay. So this first allergist didn't do either of those and said strictly avoid all fish and shellfish based on blood and skin testing, and prescribed an epinephrine injector. So parents kind of questioned the initial diagnosis given his previous tolerance, went to a second allergist who who not only did shrimp and did shellfish and fish testing, but decided to do all tests, broad panel, which didn't make any sense to me. So now he's sitting there with positive eggs and peanuts and corn and wheat. And based on the description, was previously tolerating all these foods with no problems. He never really liked scrambled eggs, but not a lot of kids do. But he tolerates fresh toast, pancakes, and waffles. So, I mean, I don't think we need to belabor this point. And this is kind of, again, showing you the difference in practicing allergists, across the board. Because, again, this wasn't 2 allergists in the same practice. This was 2 separate allergists in different offices. Recommendation based off of that test, continue to avoid fish and shellfish, but now avoid peanuts, eggs, milkweed, and corn and soy. So you took a kid who was enjoying a healthy diet, loving fish and shellfish, and now you've brought him in and he's avoiding all the things he loves, including peanuts, eggs, wheat, milk, corn, and soy. So now you're basically putting this kid at risk for nutritional deficiencies and eating problems because you've taken away most foods that he can eat. And I'm not making this up. This really happened. So now parents are coming in, and the kid absolutely hates allergists now. He thinks we're all quacks, and he's only 8. So they're like, well, what do we do? This is now he's avoiding all these foods, and we're so nervous to feed him anything now. So they're just very kind of distraught, upset, and really want a more finalized approach. So I basically went through the whole story, as again, talked about shared decision making, talking about what the testing means, explained what the gold standard for these tests are, and the fact that he was tolerating these foods prior is basically confirmatory that he's not allergic. So I basically said ignore basically pretend like you never showed up to an allergist before. Now, because they've been hammered over the last couple months with avoid, now they were too scared to do it on their own. So I said, that's fine. We're going to do an Alaskan pollock challenge in the office, this is the most common fish found in imitation crab. So just to kind of ease their fears and kind of get them back into feeling confident, we did a challenge. Of course, they passed. And then they've since introduced all the foods at home and are not avoiding any foods. So they came in for seasonal allergies, and they came out with a whole big mess. So this is an example of not only, not staying up with the literature, not being, cognizant of cost and price points, and not even taking into consideration the clinical history and the well-being and kind of mental fortitude of your parents and patients. Like, taking a kid who was eating all these foods and then completely changing their life around, that's a big ask, and it's not something to take lightly. So you need to be confident with these recommendations and not kind of just think, oh, no big deal, just avoid, half the foods that kids eat. So definitely please make sure keep up with the literature, know what you should be doing with regards to these types of tests. A great way to stay up to date is really being active in your local, regional, and national meetings. Of course, the college is coming up here soon. So yeah, stay involved, stay up to date, and that way you won't get embarrassed by your colleagues when you're referring these patients to them. So second case, again, last week, 12-year-old with allergies, EIB, eczema, peanut and cow milk allergy. Original reaction to cow's milk occurred as an infant, had hives with milk exposure, as well as really bad eczema at the time, an anaphylactic reaction soon after for peanut, and then broad panel food testing was done as an infant, but hadn't followed up since. So had been out of connection with an allergist for a while. So serum testing is shown below, as well as the skin prick test. Currently avoiding all forms of milk as well as peanut. Would you challenge this patient to anything based off of this history and the testing provided?
Do you mean challenge to peanut or milk? Like, was the question?
Any challenges, whether it's peanut, milk, whatever you think.
Peanut, I probably wouldn't do. I think with the AR82, I mean, being greater than 100, with him having the actually, let me read this again. Peanut. Yeah, I probably wouldn't challenge the peanut. Dude, especially with the AR82, like greater than 100. I mean, with this increase of the systemic like reaction, I mean, based off his component testing, and milk. I could possibly consider doing like a baked milk challenge, but yeah, I mean, I wouldn't do like a whole milk. I mean, kind of challenge. I mean, based off of the milk level of 20.5. With the previous allergic clinical history too for milk. Would kind of be my thoughts initially.
Good. Yeah, and that's what we did. We did a baked milk challenge, and the patient passed. Lost to follow up until about 4 years later. Had been doing well, tolerating baked milk products with no issues. Some exposure to pancakes and waffles on occasion with no reaction. We repeated some testing, which I compared to 2019 for you here. Now, based off of doing well for baked milk for 4 years, and then these updated values, would you continue just staying on the baked milk, or would you consider doing a whole milk challenge at this point?
Oh, with the milk of 4.82. I could consider doing a whole milk challenge kind of at that point. Or I could still even avoid it, honestly. Yeah, so I got the numbers.
Yeah. So, I mean, some of the data, especially with the skin prick testing, would suggest that this patient might fail a challenge, but based on the clinical history of tolerating baked milk, as well as pancakes and waffles, and the fact that, they were, milk is such a ubiquitous, component in a lot of things, we decided to move forward and do a challenge, which patient passed. So, was really happy with getting milk off the list. And then we started peanut OIT soon afterward, and she's doing really well on that. So, yeah, again, on paper, some of these values would be a little scary to consider doing a challenge, but as I mentioned, looking at the clinical history, taking into consideration, the effect on quality of life, these are scenarios where challenges can be done, and as we saw, patient passed. This is a work group report that we did a while back that just kind of highlights the reasons why some allergists don't perform a lot of food challenges in their office. It was distributed to a decent amount of allergists back in 2019. There was a previous study that asked similar questions in 2009, so it was a nice way to compare between the two cohorts. And pretty much lack of time consistently is the number one barrier to performing challenges in the office. So not uncommon based off of a very busy clinical practice. You're trying to get patients in and out, and if you're spending hours doing a graded challenge, that can really take up a lot of time. And as you saw in 2019, not only a lot of time, but it takes up a lot of office space and locks up your staff as well. Really kind of not putting patients in the room, but dosing challenges, watching patients doing vitals. It's a lot of time and effort. The risk for adverse events was more persistent in 2009, but I think that the kind of day-to-day nitty-gritty of running a practice is much more front of mind for patients or for physicians than safety. About 58% generally performed about 1 to 5 challenges per month. I'd say I perform 1 to 2 or to 3 challenges a day. 82% obtain written informed consent, which I was surprised with. I would assume that 100% would, just based off of medical legal issues. So, these are some interesting data points, but again, just point towards how busy these offices are and how difficult it is to do this. Now, the fellowship training was difficult to assess because some patients were older. This was before the ACGME requirements requiring fellows, I think, I don't know if it's still a 5 minimum, but at least at the point of this publication, it was at least 5 challenges. Now, the problem with that recommendation is you could see 5 super easy challenges where no reactions occurred, and you really wouldn't learn much from that. I think the majority of the learning that takes place with food challenges is actually watching and seeing patients react in real time, because again, experience really counts so much into figuring out, okay, is this subjective, or are these obvious objective complaints? Is this patient nervous and anxious, or are they truly having an issue? There's so many things that go into challenges, and it's just the more you do, the better you are at recognizing some of these events. And I've gotten better at kind of figuring out, oh, this kid's not going to pass because as soon after the second or third dose, they start getting a little flushing in their ears, their earlobes get red, and then you can see them clearing the throat every few minutes, and then they start sniffling. And while maybe an allergist that's not experienced might say, oh, that kid has a little seasonal allergies, no big deal, that's the writing on the wall that things are going to get worse, and they typically do. So it's just a matter of getting more patients under your belt so that you become more confident doing these challenges. Of course, safety is always a priority, but again, 58%, only 56% had emergency medicine readily available in their offices. So it's really important to be kind of ready to go, have a staff and physicians that are well versed in kind of how we do a challenge from start to finish. I'll show you some preparation that really can help, but preparation is totally key, and you really want to spend a lot of time with parents and patients discussing the whole scenario of the day, reviewing the blood work, going through the nuances of the diagnosis, just again, so there's no surprises. Making sure you're, again, what is a challenge, procedures and goals, what's the reason why we're doing this, and what are the risks and benefits, what are the likely outcomes, what happens if there is a reaction, what do we do, review what medications to stop prior to the challenges. So it takes a lot of effort to do this, but once you have that pattern in place and it's part of the culture of your office, then a lot of these things don't get missed. And so rarely do you have a challenge that goes awry before you start because everyone's on the same page. Of course, consent is, in my opinion, very important. Not only to protect you, but to protect the patients so that they know what they're getting into. And then, timing is important too. Letting parents know, okay, how long is my kid going to be in the office for potentially? If this goes well, what's the typical time course? If it goes poorly, how much longer would we need to be in there? Do they have, a driver, or do they have games, etc.? And we'll go over some things to distract kids, especially younger infants, when doing these types of challenges. We talked about informed consent. In our office, we do color-coded charts that kind of cut down on error especially for OIT. So these are OIT charts of patients that come in for their dosing. So every food has a specific color. We've got timers. We've got all these kind of redundancies in place to make sure we're not dosing someone with an inappropriate allergen or giving them a higher dose than they should. So it's really important that you kind of put redundancies in for safety for sure. Pre-assigned roles is really important. Everyone who's taking care of that patient during a challenge day should know, what their role is, who's doing the assessments, who's doing the vital signs, who administers the food. Is there a plan in place to contact the physician if they're busy with another patient? I could see a situation where a nurse would be nervous to interrupt a doctor in an office with another patient when the patient's having a reaction and they don't know what to do. So, those delays can lead to bad outcomes. So it's really important to make sure that everyone's aware of, hey, if there's a reaction, you come in and get me. We'll discuss. Interrupting patients isn't the end of the world, and really have that plan. And then, of course, what do we do if the reaction goes sideways, or we need fluids, or we need to call EMS? Do we have that protocol in place? A lot of allergy offices are hesitant to do challenges if they're not near a hospital system. Again, I don't think that's a prerequisite to do challenges in an office, as long as you're doing them appropriately and with safety measures in place. So, even a rural allergist can perform challenges as long as they follow these protocols and they have a safety plan in place. So, especially if you own your own practice, it's really important to kind of drill this into your staff for sure. Proximity food challenges are also very helpful, and this is really great for families that are super anxious and concerned that their food allergen might be hiding in plain sight anywhere and everywhere. It's in the air, it's in the ducts, it's in the seats. It's this kind of overarching, pervasive kind of mind-numbing anxiety around peanut or some sort of food allergen always around, and the risk for reaction is always there. So I think this is one of my favorite things to do with those patients, because it really helps desensitize or de-fear these patients. And it's very easy to do. And of course, I've never had a bad reaction with these challenges, because most patients can tolerate this very well. So we basically have an open jar, or the food they're allergic to, open to the air near them, and we slowly bring that jar closer and closer to the patient in different intervals, and then wait a certain amount of time between the intervals, and that really will give the patients and parents more confidence that being near the food, breathing in the food, is not going to cause a problem. Now, of course, we're not sautéing up shrimp in a saute pan in front of them. This is raw products, but especially for peanut and tree nuts, this can be really helpful. And then if we do well with the airborne part of this, we then move on to skin contact. Dabbing a small amount of peanut butter on the arm, and rule out or look at contact exposures. So, this is a very simple, very easy thing to do that, again, gives patients and parents confidence that they're not as maybe severely allergic as they thought, and can really help reduce some anxiety around scenarios where, they were avoiding and their quality of life was poor because they weren't going to birthday parties or airplanes, and now they can do some of those things with confidence. Yeah, and there was a study that looked at a lot of different foods doing this similar protocol, and they didn't have any systemic reactions, and just one urticarial reaction at a contact site. So real safe and really great for patients and parents. And then challenges, as we mentioned, a lot of surveys looking at how important these are for alleviating anxiety, reducing stress. And again, it didn't matter if they passed or failed. Everyone really truly found it helpful because at least it gave them some insight into the disease. So I think these are great surveys to give you confidence that doing challenges is the right thing to do. So we're going to use this as a teaching tool too, both during and after a reaction, should there be one. So I never let a good failed challenge go to waste, because you're right in the middle of a scenario where you can really teach them about the signs and symptoms of anaphylaxis, about what an epinephrine injection feels like, how does it feel like when you're getting it, and how does it feel like afterward, how quickly do the symptoms resolve. This is a time where you can really instill a lot of confidence. And the last thing you want to do is make this a scary event for them, coming in, rushing in, seeing a reaction occur and freaking out, or yelling at people to like, give me epi-stat, and like being really aggressive and scary about the situation. Take a calm, deep breath, talk to the parents and the patients while you're doing things, explain what you're doing, talking about the whole process. And I can't tell you how much this is helpful to really ease the fears, because they realize that while an anaphylactic reaction requires treatment, it doesn't need to be a freak out moment. We can take it calm and collective. We can inject the medicine. We can see things improve, and it really relieves a lot of anxiety, especially around, I think, older kids and teenagers. There's a lot of anxiety about actually injecting themselves and not and being scared it's going to really hurt. And getting that injection in the office just gives them a sense that, wow, the epi doesn't really hurt as much as I thought it did. So great opportunity. Don't let that pass you by. And of course, coaching parents and kids after a past challenge is important too. Can't tell you how many patients will pass and then not introduce that food back into the diet, either because the kids didn't like it or they're still nervous. So really, reiterating the fact that this needs to be continually included in the diet moving forward. Not every day, but give them some guidelines on how often they should continue to include these foods, just so they don't go years or decades without ingesting it. Because I have had some situations where there's a past challenge, like to cashew, for example, and they come back 6 years later and they've had a reaction to cashew because they continued to avoid it and their numbers went up. So important conversation to have as well. Toddlers and infants are a little bit more tricky, and sometimes you'll get a failed challenge not because they had a reaction. It's just they refused to eat enough food to be considered kind of a full serving size. So definitely take into consideration the age of the patient, allocating maybe more time if you need for those patients in your schedule. But of course, they're verbally limited. They're slow eaters. They're picky eaters. We're going to change the goal dose, of course, based on the size. We have to watch out for contact reactions because kids can be pretty messy. So oftentimes we'll kind of spoon feed them and try to limit contact with the skin as much as possible. So this is always a more difficult challenge to do for some kids. So we talked about appropriate portion sizes, appropriate vehicles, make sure we're not avoiding choking hazards, and really making sure that there's a lot of options for the kids. Bring in chocolate sauce, or anything that the kids like to mix, jellies, whatever, sugar. Just the sky's the limit, just so they can get down enough to really be considered a past challenge. And again, timing is key. Avoid nap time. It's one thing that a lot of people, especially who don't have kids, forget about. Like, don't schedule a challenge like right when a kid's getting tired and about to fall asleep. It's just not going to go well. So we usually do it first thing in the morning. That's usually the best time for little infants and kids. But really pay attention to that. Vital signs, of course, making sure you have appropriate blood pressure cuffs, and just know what the appropriate vital sign is for an infant, so you're not, you're watching those vitals and making sure you're doing it appropriately. And for infants, the good news is the vast majority of symptoms with a reaction is in the skin. So, these reactions typically are urticarial in nature, some angioedema at times. But as the kids get older, the angioedema increases, but definitely cutaneous symptoms are the most common side effect or symptom. Flushing, in addition to urticaria, I would say are the two things you'll see the most of. Tablets, as I mentioned, not just vehicles with which to feed the foods, but like toys. Like, bring everything you can to make sure that they're engaged and distracted. So all those things can be important. The goal amount of food can be kind of subjective. There's not like a set amount where you have to get to. Again, equivalent of a serving size of the food is where we shoot for. And you can develop kind of typical protocols that in your office, but this isn't complicated. It's not rocket science. Take the full amount that you want to feed them, the standard serving size that you want to get to, divide it in half, divide it again, and typically I do 4-step challenges. I don't like to do, there's some people that I've seen that have done 12 or 15. Like, you're getting to the point where you might be desensitizing. You want to do a short, quick challenge that has increasing escalations, where you're really challenging the patient to make sure they're truly not allergic. So you don't need to get out a calculator or even a gram scale. Now, we do that with OIT. We don't do that with food challenges like this. So don't make it harder than it needs to be. It's pretty simple to do. So this is a great protocol to use. And then the initial dose really kind of depends on the clinical history as well as the size of the patient. So, we have high risk and low risk challenge protocols in our office that I've kind of developed over time. So if there's a patient where, it's an OIT potential candidate, but they haven't really eaten the food before, but their levels are high and they're really interested in knowing, I'll do a high risk challenge potentially on something like that, versus, a kid that has a very remote history, levels are very low, it looks like this kid's gonna be a really good pass. So that'll take time and experience as you get more reps in, but we usually have a high low dose risk challenge in our offices, which is good. And again, I'm typically 4 doses is where I usually go. If it's a high dose challenge, I might give 5. I wouldn't go past 6 doses, just again because we want to make sure we're not going to too many doses to get a false positive for a false negative for a challenge. Timing too can kind of, depending on the patient, baked products tend to be more delayed in reaction. So oftentimes we'll have more time in between doses for those patients. For most, it's about 15 minutes in my practice. We might go a little higher for other challenges like high risk or baked challenges, maybe 20 to 25, depending. Again, you can feel out what feels good to you. But definitely I'd say baked challenges are the most delayed, and we've had even scenarios where patients have passed, but they'll call on their way home, or when they just get home with vomiting because they had a delayed GI reaction to the baked product. So look out for those. And then sometimes, again, you might get a kid who is so stressed that they can't finish the product, or they're too full and they won't eat anymore, or they can't stand the flavor or the texture and they won't eat it. So again, there's no standard protocol for that, but you're trying to figure out, okay, how much was consumed? If they were on the higher end of that challenge, maybe you say, well, you know what, the kid did really well, had 0 symptoms, ate a decent amount. We didn't get to the full serving size, but maybe, in the next couple of days, let's keep on pushing that dose at home, and maybe at a home environment with TV and some other things around, they can get the dose in, and we'll see how things go. If they maybe only got 1 or 2 doses down, then we might have to say, listen, maybe the kid's too immature at this point, or we're just not able to do this in a way where we can really truly be confident that he's not allergic. Why don't we come back in 6 months and try again when the patient's a little older? So you have to make those decisions, but not everyone's a complete failure. If they don't get all the way through, you can moderate it and modify it based off of your kind of gut instinct and the patient history. And of course, we talked about subtle signs and symptoms that you get better at noticing as you become more experienced in challenges. So ear picking, tongue rubbing, kids putting their hands in their mouth, scratching, just kind of a fun, energetic kid or toddler who all of a sudden becomes really fussy, quiet, and withdrawn, especially when Bluey's on or some sort of show. So you can kind of see that and trust parents. I mean, again, you're always factoring in anxiety with these patients and parents, but some, especially moms, are really good at saying, my kid does not look right. So don't ignore those and say, oh, she's just nervous. Take those comments into consideration when you're evaluating, because oftentimes they're right. And they might notice subtle signs even before the kid reacts, and you'll come in and they'll be like, I told you so. So don't ignore those comments. And then we talked about IgE versus non-IgE mediated symptoms. So there's lots of nuances there, but in general, these are, most challenges go well, but you want to make sure you know that the nonverbal cues as well. Stopping criteria is something that we've kind of put in place in our practice. My staff has specific things, like if this happens, like don't like take it upon yourself to continue the challenge and do what you think is right. I want you to come get me, and you stop the challenge immediately. So there's certain vital sign levels, signs and symptoms that I want to be brought out and evaluate the patient myself, so that I can make a determination: do we stop the challenge or not? So have those kind of set standards in place before you kind of give nurses the ability to kind of do these challenges, because rarely in a busy clinical office are you individually dosing each patient. If you're doing a couple challenges a day, you have to see patients too. So you have to have trust and confidence in your staff that they're going to do what's right. And that's where these protocols come into place, where they're written down, everyone knows them, and they can refer back to them if they forget. So that's where redundancy and safety comes into play here. Definitely demand for challenges, at least in our practice, has gone up drastically over the last few years. The previous recommendations for early peanut introduction, combined with the kind of onslaught of OIT patients that have been referred to us, have really upped our OIT and oral food challenge game. And so I think this is only going to continue to increase. And so we need more and more allergists out there that are able to do these challenges. And whether or not you offer OIT or not is beside the point. There's room for these challenges, and we need more and more doctors to do it, because there are a lot of patients that are looking for this, whether they know it or not. There might be some patients that don't think they need it because they have a true allergy and they need to just continue to avoid it. But I'd say out of all the OIT referrals I get, about 25 to 30 don't even have a food allergy. So it's 25 to 30% is a pretty high number for kids that are being specifically referred for a food allergy treatment protocol. So it's not, there's room for improvement out there, and you guys can be the first line of defense with these challenges. So as we mentioned, how important these challenges are, especially for infants and toddlers. There's no age that disqualifies you from a challenge. So you can do this in all comers. And again, most reactions, even in the office, are mild and cutaneous. Of course, we do require epinephrine for a lot of our challenges. We have had no bad outcomes or deaths with regards to challenges. I think we've had one EMS call where they took a patient in because of a blood pressure drop, but we did get a line in and had fluids running, and that patient did fine. But again, these are very safe and easy to do, as long as you are prepared and do everything beforehand to make sure that it's safe. So preparation is key. So again, take-home point today: in the hands of an experienced and trained allergist, oral food challenges are safe and reliable in our offices. So thanks, guys. Any questions, please feel free to ask. Hopefully some of these patient cases gave you some insights into what you might be seeing in your clinical practices when you go out in the real world. But yeah, hopefully this was helpful.
Thanks, Dr. Greiwe. It was terribly helpful, and I appreciate you and the Bernstein group, because you all have been great contributors to our COLA program. Let's open this up to questions in the audience.
Hey, thanks for talking, Dr. Justin. Oh, never mind. You want to go ahead, Taf?
Sure. I just had a quick question. So for some of your oral food challenges, we kind of have our protocol in place in terms of, going through our checklist for the patient, and then also medication review and holding antihistamines. But some of the situations that we've ran into are patients with like chronic urticaria. So how do you handle those patients when it comes to your food challenges? Do you, if they're well controlled, do you just continue with having their antihistamines? Do you wait until they're completely off, which could be who knows how long when? So just wanted to see what your thoughts were on that.
Yeah, so you'll run into those patients every once in a while. I mean, if they're very poorly controlled and covered in hives, of course that's not the best time to do a challenge. But as you mentioned, in a case where you have a CSU patient or a physical induced urticaria patient who's really well controlled on antihistamines, we take that into account. But we still would proceed with the challenge and continue to stress the importance of including that food moving forward. And if there's any additional issues at home, then they'll let us know. But I'd say the vast majority of times we're giving enough food in that challenge date that you're going to kind of break through that antihistamine barrier, and you're going to get a reaction if they're truly allergic. So we haven't had too many issues with those chronic hive patients staying on antihistamines with challenges.
Okay, thank you.
Hey, quick question I had. So, do the patient that's just sensitized with, Bimba's never had any Bimba has never tried the food. And so kind of are you still pretty comfortable doing a challenge depending on what the IgE level is or the number? And so strictly just sensitization. I mean, even if the numbers are like, of course, really high. I mean, that was one question I had.
Yeah, so similar to that slide I showed earlier, with that younger toddler who had broad panel food testing, had never eaten any of the foods, and I mentioned his sesame level was 72. Now his total IgE was really high, but again, based off of a really good clinical history, there was no obvious reaction. The kid was avoiding a myriad of foods, and so you're setting that kid up for some malnutrition and some picky eating moving forward. So mom was really concerned, and so we did a challenge, and the patient passed. So if you were to look at the levels of IgE based off of clinical studies, and you just kind of ignore the clinical history and just say, well, a 72 for sesame is 100% allergic, there's no way that kid's going to pass, you would have failed to see that result. So again, I'm not a proponent of being a cowboy and just kind of challenging everybody willy-nilly, but in the right situation with a good clinical history, blood testing and skin testing is just that, they're tests. That's why oral food challenges are the gold standard. And again, until we get better, specificity and some of these component and bead assays that we were mentioning, hopefully that'll be able to steer us in the right direction and provide more accuracy when we follow up with the food challenge. But for now, you're kind of at the mercy of these poor, blood and skin test results. So there's still there's an art and a science of food challenges, and unfortunately, your guys are at a point where you haven't seen or developed that art yet because you haven't seen enough. But as you get into practice, you will develop the art, and you'll hopefully your guesses will be more accurate as you get through to more and more patients. So yeah, never take these tests at face value.
Yeah. And last question I had. So a patient that's previously tolerated a food, of course, gets testing. I mean, that's like high or something like that. And then they, of course, start to avoid the food. How long after that they've been avoiding the food? And so are you more concerned that you probably need to bring the kid into clinic to challenge the kid versus, just incorporating that food back into the diet? So like when they have actually become allergic because they started to avoid the food. I mean, if that question kind of makes sense.
Yeah. So I would say that, for the patient we described earlier, where, just a few months ago, they were eating all these foods and had no problem, and all of a sudden they were told to avoid them. There's no need, in my opinion, to follow up with a challenge in the office. Those patients can be instructed to go home and eat those foods as they were before. Now, if you had a patient who was told to avoid peanut despite tolerating it at 12 months, and then they come back, 8 years later and say, am I still allergic? Then that likely would be an easier place where a challenge would be appropriate. So, there's not a specific time frame, but I would say, a few months is not something that I'd be too concerned about, but a few years, it probably would be an easier approach to do a challenge in the office if they've truly been avoiding that food for a long time. So, but there's no set standard amount of months that you're looking for with that. It's more of just kind of history and feel.
So sounds good. Yeah. Thank you so much.
Yeah.
I had a few quick comments. The 2009 work group, revised in 2020, has that list of when to stop challenges. You had that on your presentation, and it said if there were 3 or more urticarial lesions, then they would consider stopping. How do you explain the 2?
It's they're guides, so it truly is still, eyes on, in the heat of the moment. What are you going to do, and how do you think the patient's doing? So, if you see 3 lesions versus 2, are you going to stop? I mean, again, it depends on your experience and how you've treated those patients in the past. But to me, it's more of a feel. I have stopping criteria for the nurses just so they know to get me, so that I'm not, in the office, in the patient room waiting, and all of a sudden I come out and there's a really bad issue going on. So it's more for my ancillary staff, the first line of defense, as this is my threshold that I want to be contacted for, and then I make that decision in real time. So, are there patients where I've continued to challenge if they have, a few spotty hives? Yes. Others maybe I've stopped, and it depends on the clinical history. There's so many factors that go into this, so it's really, experience is so important in this space, and that's why I really would encourage you guys to get in on as many food challenges as you can during your fellowship, because you want to see those fails challenges, you want to see those pass challenges. It just gives you more and more data points to kind of utilize when you go off and do it on your own.
Yeah, thanks for sharing that. We do about 200 challenges a year at our facility, so our fellows get a lot of experience. And I know there are times where I have proceeded after a couple of highs, and there are other times where I called it. And like most things in medicine, it's, you know, talk with the parent, the patient, see what their comfort level is, kind of review the history, and then move forward. So yeah, not always black and white answers on these things, but it's nice to share everybody's thoughts on it. My other question, and I'll be done, is what do you think is an acceptable pass-fail rate? You know, if you wait till you get 100% pass rate, then you've waited way too long on a lot of kids. On the other hand, if you had like a 50% fail rate, then maybe you're challenging a lot of people too early. We're currently in our group about 80-20, 80% pass, 20% fail through the year. And that's all foods, all ages, all comers. So just curious on what your thoughts are.
Yeah, I would say for our non-OIT patients, that's I think a good metric to shoot for is that 80-20. You know, it might be a little off kilter for these kids that are really interested in OIT but have never eaten the food before, and you know, and after a long discussion with parents, we're like, okay, let's try and challenge just to see, is this kid truly allergic or not. So that failure rate might be a little higher, but I would say I don't think it's anywhere near 50-50. It's you know, that might be 30% failure rate versus 20. But yeah, I think that's a good metric to shoot for, because like I said, we shouldn't be cowboys doing this. Like, this isn't, you know, Wild Wild West where you're just challenging whoever. You know, you're basing this off of a lot of different factors. And again, if you're good at this and you've kept up with literature, you can use that information to make informed decisions and be fairly accurate. And I think an 80% success rate is reflective of that.
So we had a talk by Dr. Portnoy recently, and he lives in the land of likelihood ratios and predicting success on challenges. And then the next phase will be the AI prediction of this. Yeah, so I'm not sure when that's going to come into play, but it's an interesting thought at least, and I look forward to something that helps me make better decisions.
For sure.
Okay. All right. Well, I think due to the time, we'll go ahead and discontinue or stop the discussion. But I appreciate you being here again, Justin. Thanks for always contributing, and hope things are going well for you all.
For sure. All right, guys. Good luck with your studies. We'll talk to you.
Thanks, everyone.